Welcome to this video on the secondary check, a critical head-to-toe assessment. The secondary check is the detailed assessment that follows stabilization of life threats. It helps us identify the chief complaint, mechanism of injury, associated injuries, and any red flags. This assessment comes after the primary check, once the patient is stable. Our learning objectives are to describe when to begin the secondary check, collect a concise sample history and OPQRST symptom profile, perform a systematic head-to-toe screen using D-CAP-BTLS/dots, and recognize red flags that require immediate escalation or EMS handoff. Skilled assessment is always organized assessment. The secondary check begins only after immediate life threats are addressed. Continue ABC or CAB monitoring if the patient remains unstable. Use a rapid assessment for serious mechanisms of injury or altered patients, and a focused assessment for isolated complaints when the patient is stable. The sample history structure helps with concise questioning. S stands for signs and symptoms. A is allergies. M is medications. P is pertinent history, and L/E stands for last intake or events. Be organized and avoid random questions that waste time. OPQRST-I deepens the signs and symptoms part of sample. O covers onset and provocation, like what makes it worse or better. P, Q, R, S, T, and I cover quality and region, radiation, severity, time, and interventions. Our head-to-toe scan uses D-CAP-BTLS to quickly assess for findings. D is deformity, C is contusion, A is abrasion, and P is puncture or penetration. B is burns, T is tenderness, L is laceration, and S is swelling. Always inspect first, then palpate. Compare bilaterally when possible. Red flags change the urgency of care. For the head and neck, look for battle sign, CSF from the nose or ears, and neck pain or neurological symptoms. For the chest and abdomen, look for breathing difficulty, chest instability, crepitus, or abdominal rigidity. In the extremities, watch for open fractures, absent distal pulse, or loss of motor or sensation. Consider this assessment case. A basketball player is alert after a fall, reporting shoulder and neck pain with tingling into the hand. Even with a visible shoulder injury, the tingling indicates a need for cervical spine precautions before continuing with a focused shoulder exam. To summarize the key takeaways, secondary assessment starts after stabilization. Use a systematic script like sample plus OPQRST-I. Always inspect before palpating. Remember, red flags override return to play pressure. Ensuring patient safety is the priority. This video is based on best practices from the American Heart Association, American Red Cross, and established assessment frameworks like SAMPLE and D-CAP-BTLS. Emergency care education requires hands-on skills verification and adherence to local protocols and current certifications.